Bismillahir Rahmanir Rahim. This lecture is about juvenile idiopathic arthritis. Juvenile idiopathic arthritis is one of the common rheumatic diseases in children, occurring at a prevalence of around 113 per 100,000 children, and it is a major cause of chronic disability. The etiology is unknown, but it has been hypothesized that two events must occur together. First, the presence of immunogenetic susceptibility, and the occurrence on top of an environmental trigger. There are specific HLA subtypes that confer varying degrees of susceptibility to juvenile idiopathic arthritis. Juvenile idiopathic arthritis is one of the common rheumatic diseases of childhood, and it's diagnosed if it starts before the age of 16 years, because we know that if it starts after that age, then it will be the adult type rheumatoid arthritis. The diagnosis of arthritis rests on the criteria that I have mentioned a few slides ago, and the duration in juvenile idiopathic arthritis is 6 weeks or more. This indicates that this is a chronic arthritis. You have to exclude other forms of arthritis in order to say that this is an idiopathic arthritis. I quoted this table to you from the textbook of pediatric rheumatology, and it indicates the criteria that I have just mentioned, but in addition, I want to show you here the types of juvenile idiopathic arthritis. These types are defined by the picture of the disease in the first 6 months. If the number of affected joints is equal to 5 joints or more, then this is polyarticular juvenile idiopathic arthritis. If the arthritis affects up to 4 joints, then this is the oligoarticular or the polyarticular type. And if the onset of the disease occurs with the characteristic fever, which is a quotidian fever, in other words, fever that daily rises to 39 degrees centigrade and then comes back to normal, this is called systemic onset juvenile arthritis, juvenile idiopathic arthritis. The other types of juvenile idiopathic arthritis that are included in the classification are psoriatic arthritis, which is arthritis occurring in psoriasis. This is a skin disease that you will learn about, and as well as other forms of arthritis. This table is from Nelson Essentials, and it shows the features of the major types of juvenile idiopathic arthritis. We have mentioned the number of joints in each type, but what about the type of the joint? In the oligoarticular, it takes the bigger joints, the medium to large size joints. The polyarticular, because it takes a big number of joints, so it will also affect the small joints of the hands, for example. Of course, the spondyloarthropathies, from the name, we can tell that it affects the sacroiliac joints, maybe the spine. Females are more commonly affected than males in the oligo and the polyarticular type, but in the spondyloarthropathies, it's more common in males, especially around the age of 10. The systemic features are seen more prominently in patients with the systemic onset type. There is affection of the eye in juvenile idiopathic arthritis. This is a grave complication that might occur. It's not even a complication, it's a manifestation of the disease, and this uveitis is most commonly seen in patients with oligoarticular juvenile idiopathic arthritis. The anti-nuclear antibodies tend to be positive in the oligo and maybe in the polyarticular types, but the rheumatoid factor positivity is seen in patients with the polyarticular disease, and we call this type a rheumatoid factor positive polyarticular juvenile idiopathic arthritis, because there is a rheumatoid factor negative polyarticular juvenile idiopathic arthritis. This type, which is rheumatoid factor positive, occurs early, and it's usually disabling and causing deformities of the joints. Other features that help make the diagnosis of juvenile idiopathic arthritis is the presence of morning stiffness. In the morning, the child cannot move the joint, and there is gelling in the joint. This is because of the edema in the tissues of the joint. Deformity in the joint helps you in diagnosis because this is an erosive arthritis. The arthritis causes also periarticular swelling, that is edema of the surrounding tissues. Non-specific tests like high ESR, positive C-reactive protein, all these are supportive for the diagnosis, and the presence of leukocytosis also. The presence of a positive rheumatoid factor can help make the diagnosis but does not exclude juvenile idiopathic arthritis if it is negative, because it's positive only in a minority of the patients. Elevated anti-nuclear antibody titers are seen in 40 to 85% of children, but it is unusual to occur in systemic onset disease. Rheumatoid factor, as we said, is positive in around 8% of children with JIA. The radiographic changes that occur include, in the beginning, soft tissue swelling, then osteoporosis occurs, erosions of the subchondral bone, narrowing of the joint space, and destruction of the bone, and the end result might be total ankylosis and fibrosis of the joint. The photographs here show affection of the small joints of the hands in patients with juvenile idiopathic arthritis, the polyarticular type. In the older patient here on the right side, we can see that the juvenile idiopathic arthritis has caused deformities, flexion deformities of the fingers, and this is as a result that it developed early, and it is of the rheumatoid factor positive type usually. The one on the left shows that the juvenile idiopathic arthritis affected this young child or an infant or young child at an early age, as we can see, and it is of the polyarticular type. You can see that all the interphalangeal joints are affected, as well as there is also edema on the dorsum of the hands, implying an underlying inflammation in the carpal joints. These are X-ray pictures of patients with long-standing juvenile idiopathic arthritis, and here we will see the effect of the disease on the joints and the disabilities and deformities that it causes. In the X-ray on the right-hand side, you will see that there is flexion deformity of the fingers, and if you look meticulously, also you will see that there is very much decrease in the bone density, what we call in X-ray findings osteopenia. You can see that the density of the bone is almost as equal as that of the soft tissue. This osteopenia results from the disease itself because of the high levels of tumor necrosis factor, and they also result from corticosteroid therapy. Therefore, we have to avoid as much as possible giving the patients corticosteroids. If you also look meticulously more on the X-ray, you will see that there is complete loss of the joint spaces in the interphalangeal joints. Usually, when you look to an X-ray, you will find that there is a dark line or dark space between any two bones. Here, this space is replaced by a white line, which is the erosions that occurred and the bony ankylosis that happened on top of these, the loss of the cartilage and the long-standing inflammation. The carpal bones also are amalgamated together because of the inflammation in the carpal bones and the joints in this area. In the X-ray on the left-hand side, the flexion deformities are very obvious. We can see that some joints have lost joint spaces in the interphalangeal joints of the right hand, and a bony ankylosis also is seen. There is loss of the spaces between the carpal bones. If you look to the left hand, in the photograph on the left side, you can see that there are flexion deformities. Some joints have lost the interphalangeal spaces, and we can see subluxation in the ring and little finger, also in the thumb of the hand on the left hand of this patient. The objectives of the treatment of juvenile idiopathic arthritis rest on enabling the child to lead as normal a life as possible, and to minimize the disability that results from the deformities and the adverse effects of the treatment that we give. Medications include first-line drugs, which are the non-steroidal anti-inflammatory drugs, such as ibuprofen. They inhibit prostaglandin synthesis, but they have adverse effects like causing gastritis. They may cause bone marrow suppression, hepatitis, as well as interstitial nephritis. The second-line drugs are called disease-modifying anti-rheumatic drugs. They are agents that retard the progression of the disease. For example, here the methotrexate, which is given once per week in a low dose that ranges from 10 to 15 milligram per meter squared surface area, and it can be given either orally or subcutaneously. Sulfasalazine is another example, and the anti-tumor necrosis factor etanercept. Glucocorticoids are not the main line of therapy in patients with rheumatoid arthritis. You have to remember this. We have to keep this drug only for patients who have overwhelming disease, have systemic juvenile idiopathic arthritis. You see here I've written JRA because it's sometimes called juvenile rheumatoid arthritis. Some others call it JIA. Another group calls it juvenile chronic arthritis, and the abbreviation is JCA. Anyway, steroids are given for overwhelming disease. Systemic onset disease can be given in patients in the first 2 to 3 weeks of treatment with a disease-modifying anti-rheumatic drug until the drug starts to act. So it will bind the patient through this period to minimize his agony until the drug starts to act. Afterwards, you will withdraw the steroids and continue on the DMARDs, the disease-modifying anti-rheumatic drug. It is given in patients with uveitis and can be used intra-articularly directly into the joint. Lastly, autologous stem cell transplantation is an option for patients with severe recalcitrant disease. Long-term steroid therapy results in severe toxicities. I want you, from your past knowledge, to mention 3 of these toxicities of long-term steroid therapy. Thank you.